At the outset, I would like to thank Professor Shanta Kumari, President Foxy, Dr. Girish Mane, Dr. Nilesh Balkavde, Dr. Archana Verma, Dr. Fessy Lewis, and Dr. Kiran Mai for giving me the opportunity to present before such an august gathering. My talk is on early menarche, and I would like to start with a case scenario. Here is a 10-year-old girl who is complaining of who is a standard 4th student and reports with development of secondary sexual characteristics and bleeding per vagina, deemed to be menses. Is this early menarche? No, this is a regular onset of menarche at 10 years of age. So what is early menarche? Average age of menarche is 10 to 16 years. Sometimes it may be delayed or it may come early. Overall age is reducing since many years now. Menarche before age of 8 years is early menarche. The synonym is precocious puberty. Girls may have isosexual precocious puberty, and that is termed as early menarche. Let us look at the second case. 3.5 years old girl with 2 months history of breast development and rapid growth. Single episode of vaginal bleeding and abdominal pain, no headache or visual disturbances, past history of mild eczema, breast stage is B3 bilateral, no pubic or axillary hair growth. Family thought it was puppy fat. However, the height and weight crossed the 98th percentile. Many investigations were done for her: TSH, FSH, LH, 17-beta estradiol, urgent MRI head and pituitary, urine steroid profile, bone age left hand and wrist, pelvic and renal USG. You can see in the photograph how the breasts have well developed and stage 3, even the downy pubic hair is seen in the photograph. The bone age report is as follows. As you can see, chronological age was 3 years, 6 months. The bone age was much advanced with 8 years and 9 months. The diagnosis of gonadotrophin-dependent central precocious puberty was made. Discussion was done with pediatric endocrinologists, parents, and maternal grandfather. The management included cyproterone acetate 50 milligram and injectables gonapeptide. This was a depot preparation. This third case is a 5-year-old the girl presented with the breast enlargement since 4 months and vaginal bleeding. No history of headache, visual disturbances, behavioral changes, or neurological deficits. No history of head trauma or surgery, no gelastic seizures, history of encephalitis or radiation exposure. The family history was unremarkable and perinatal period was uneventful. The height of the girl was 21, the weight was 21 kg, height was 128 centimeter, which was 2 standard deviations above the normal. The elevated areola above the contour of the breast formed a double scoop appearance with Tanner stage 4. The downy pubic hair Tanner stage 1 were present with no axillary hair. And the hand bone age, as you can see in the picture, is advanced over the chronological age by 3 years. The pelvic ultrasound revealed 9.7 by 5.5 by 6.6 centimeter uterus, which is like an adolescent age group or more like an adult age uterus with large central vacuity line. The uterine body, the cervix ratio was more than 1. So all this suggests that already the puberty has been achieved. There were 3 follicles in the ovary. Maximum diameter of the follicle was 9 centimeter, as you can see in the picture here. The GnRH test was done for this girl, which showed a predominant FSH response. The FSH had increased from 3.8 to 5 milli international unit, and modest LH response increased from 0.9 milli international unit to 7. The LH-FSH ratio was more than 1, suggesting a central type of precocious puberty. The MRI was done to exclude a CNS injury. There was no antecedent of excessive soya or estrogen intake in the girl. However, the patient lived on a farm where several pesticides were stocked, and it was asked to the family to move away from pesticides. After 1 year, the patient had a normal hormonal balance, stabilization of ultrasound measurements of the uterus and ovary, and stabilization of the height. So you can see from the past 2 case report that one of it was a central precocious puberty, which responded to agonist, and the second one was the etiology was follicular cyst, which responded to taking the patient away from the environment of pesticides. So these are the 2 case reports which very well document the etiology. How common is this early menarche? It occurs in 1 in 5,000 to 1 in 10,000 girls. However, 75% to 85% of the cases, the cause is idiopathic. Though the cause is idiopathic in 85%, a thorough evaluation is needed in all the girls to rule out serious disease, and that is mandatory for all the girls. The objectives of management include diagnosis and treatment of the serious cause, correction of menstruation, arrest of excessive maturation, maximizing the eventual adult height, avoidance of abuse, and reduction of emotional problems. To classify precocious puberty, we have 2 varieties. One is complete and another is incomplete. Incomplete, the central or the gonadotropin-dependent puberty, and the peripheral or the gonadotropin-independent precocious puberty. In incomplete, we have premature thalarchy, premature pubarchy, and premature menarche. In the complete or true LHRH-dependent precocious puberty, it could be constitutional, which we also call as idiopathic, or it could be because of some organic brain disease like tumors, hydrocephalus, severe head trauma, post-infectious, or irradiation. And all this history is important to be evaluated during the history. Now, in the LHRH independent or the pseudo-puberty, in the feminizing variety in girls, the cause could be an ovarian cyst or tumor like granulosa or a theca cell tumor, or it could be an adrenal estrogen-producing tumor, and evaluation for both is mandatory. Another very important cause is Macular-Albright syndrome, wherein the fault is the G protein defect. It could also be because of a long-standing primary hypothyroidism or an exogenous 6-steroid exposure, the history for which need to be extracted from the family. Partial forms are premature thalarchy, adrenarche, and isolated menarche. The first 2 are much more common as compared to the premature isolated menarche. Now, what is the idiopathic early menarche? In this, there is no underlying medical problem or any identified reason. The cause could be just a genetic factor, the race, the geographic location. Nutrition is suggested to be a very important factor, like, increased consumption of animal proteins, fast food, use of BPA plastic as container for foods, and use of phthalates. Obesity is also a problem because of leptin, which is involved in puberty, and it is secreted in fatty tissue, and this is supposed to have an association with early menarche. Physical inactivity is another very important factor, and stress in the family, like if there is a single parent, may cause a psychological effect and lead to early menarche. There are certain characteristics in the mother which also could be responsible, like use of OC pills, then age of the mother at menarche. If the mother is menstruated early, then the child would also be having an early menarche. For the girl, a low birth weight, inadequate breastfeeding, inadequate sleep, early exposure to sexual material may also lead to an early menarche or early menstruation. What could be the clinical presentation? These girls present with sexual development at any age before 8 years. This follows the sequence observed in normal puberty. So there will be an increase in height, there could be a telarchy and pubarchy and adrenarchy followed by menarche. In girls, early menstrual cycles are mostly irregular and initial cycles are usually unovulatory. However, there still needs to be an alert from the parents to keep the patient, the baby, the girl safe from sexual abuse. The height, weight, and osseous maturation are advanced. There is early closure of epiphysis. So ultimately, the height of the girl is found to be less. Initially, she will have a growth spurt, but ultimately, she will be having a short stature. Mental development is usually compatible with chronological age. There is an emotional behavior and mood swings in these girls, and they need to be supported by the family. Clinical features follow three patterns. One is the rapid one, which is the most common pattern, characterized by rapid physical and osseous maturation, leading to loss of height potential. It could be slow, as in the advancement would parallel the osseous maturation and linear growth with preserved height potential. Or it could be spontaneously regressive or unsustained kind of progression, which is rare. In hypothalamic hamartoma, the growth actually remains static in size, or the growth is slow. There are no other signs of precocious puberty. For symptomatic manifestations, 1 to 2 years prior, the tumor could be present and it could not be detected radiologically. However, the girl will present with precocious puberty, and only a MRI of the brain would detect the hamartoma. Hypothalamic signs or symptoms could include diabetes insipidus, eudipsia, hyperthermia, unnatural crying or laughing, which we call as gelastic seizures, obesity, and sometimes cachexia may also be present. In case of an optic glioma, visual signs may be the first manifestation and thus may immediately lead to the advice of MRI and detection of the optic glioma. So it's very important to evaluate these girls very carefully so as to rule out the CNS lesions. As you can see in this girl, the hamartoma has caused breast development, and also you can see the epiphysis you can see here. So the bone age is much advanced, and MRI is showing the features of a hypothalamic hamartoma, which is very nicely seen as a hypertense structure here. So it's very important to evaluate for CNS lesion. In this slide, you can see Macular-Albright syndrome, which is a classic triad of precocious puberty because of excess estrogen due to cyst formation in the ovaries. There are caffeolate spots, which are unilateral kind of spots, giving a coast of main appearance, as you can see here on the chest and the arm. There is polyostotic fibrous dysplasia, wherein the fibrous tissue grows in multiple bones. There is a predisposition to fractures, deformities, and limping. You can see here the shepherd crop deformity and well-circumscribed lesion with ground glass matrix here in the long bones. So this is very much diagnostic, and of course, there is a G protein defect in Macular-Albright syndrome. As you can see here, the granulosa cell tumor and the theca cell tumor also can lead to a precocious puberty because of excessive secretion of estrogen. And you can find a pelvic mass, which you can be very well diagnosed by an ultrasound of the abdomen and the pelvis. How to approach a girl presenting with early menarche? First of all, we should find out what is the onset age. Is the cause a central or peripheral? Need to describe the pattern of the pubertal development. In the gonadotropin-dependent variety, the normal pubertal development is there, but it is at an earlier age. We also need to find out how is the progression of the puberty. Is it a rapid bone maturation, which will suggest either a gonadotropin-dependent or also an independent precocious puberty. However, the velocity, the height velocity need to be very well documented. Presence of headache and seizures would indicate a CNS lesion. Previous history of CNS disease or trauma, radiation, infections, again, points toward a CNS etiology. And we also need to find out the secondary sexual characters are virilizing or feminizing. In case they are feminizing, then it could be a sertoli cell tumor, or in case of virilization, the pointer is towards congenital adrenal hyperplasia. Another thing which has to be inquired into is the exposure to exogenous steroids. It could be medicinal, some medicine, Ayurvedic medicines also are responsible, or some cosmetic sources, some creams which are used by the girl. The timing of pubertal onset of parents and siblings also should be inquired, and family history of similar symptoms should be looked into. As far as the physical examination is concerned, we need to measure the height, the weight, and calculate the height velocity in centimeters per year. The pubertal staging, the breast staging, the pubic hair staging needs to be done in the Tanner staging. The abdominal examination needs to be done to palpate for a mass. It could be an ovarian tumor. An adrenal tumor is actually not palpable and could be picked up by an ultrasound. Neurological examination is mandatory. Eye examination to look for papilledema, the visual field, and of course, looking for signs of virilization like ambiguous genitalia, hirsutism, balding. All these are important in case of congenital adrenal hyperplasia. Dermatological examination to evaluate for capillate spots are important in the Macular-Albright syndrome. Apart from that, what is important is the investigation. Initially, the LH and the estradiol level itself would tell us whether there is a precocious puberty. The cutoff levels for LH are 0.3 international unit, and for estradiol are more than 10 picogram per ml. If the LH is above 0.3 international unit, it is the 100% specificity is there for LH, and there may not be any need to do a GnRH test. If you're doing a GnRH stimulation test, we could use leuprolide 20 microgram per kg, and LH is measured at 60 minutes and 120 minutes, whereas estradiol is measured at 24 hours. Triptorelin can also be used at 0.1 milligram per meter square. LH is done at 3 hours and estradiol is done at 24 hours. In an ultrasound, you can see that the pubertal uterine length, which is 5 to 8 centimeter, the uterine body to cervix ratio of 2 to 3 is to 1, the echogenicity of the endometrial echo, and pear-shaped uterus may be seen. Uterine volume, if more than 2.8, indicates a pubertal type of growth. So ultrasound actually is very important, and if you find a pubertal kind of the uterus, the length, the cervix and body ratio, then it indicates a precocious puberty. MRI is important to find out the development of the puberty and reveal any CNS pathology. Now, if you do a serum LH concentration, and if you find that the basal level of the LH is markedly elevated, then it confirms GDPP and no need for GnRH stimulation test. If the basal level of LH are low or intermediate, if LH and FSH levels not increase with GnRH stimulation, then it is a GIPP. If LH and FSH increase with GnRH stimulation, it is a gonadotropin dependent type of precocious puberty. Management depends on the cause of the precocious puberty. If it is gonadotropin dependent and identifiable, CNS lesion is seen, the therapy has to be directed towards that pathology. If no CNS lesion is seen, then the primary treatment is a gonadotropin releasing hormone agonist. The GnRH agonist slows the accelerated puberty and improves the final height. The treatment, however, the decision depends on the child's age, the rate of pre-pubertal progression, height velocity, rate of bone age advancement. So the treatment has to be started in lieu with and in teaming up with a pediatric endocrinologist as well. The recommended dose of GnRH agonist is leuprolide acid depot at a dose of 140 to 300 microgram per kg per month intramuscularly. Triprolinic acid depot is 60 microgram per kg per month intramuscularly. 3 monthly formulations of these agonists are also available and equally effective. Other options are subcutaneous injection of aqueous leuprolide given once or twice daily, total dose of 60 microgram per kg per 24 hours. Intranasal administration of GnRH agonist naproxen given at the dose of 800 microgram BID. These results are showing a very promising type of outcomes with decreased growth rate to age-appropriate values, enhancement of the predicted height of the girl. Breast development may regress if the Tanner stage of 2 to 3 has already been reached. However, if stages 3 to 4 have been reached, the breasts remain unchanged. The pubic hair remains unchanged, stable, and may progress slowly towards during the treatment, reflecting that there is a gradual increase in adrenal androgens. The menses cease. Pelvic sonography demonstrates a decrease of ovarian size and the uterine size as well. The serum sex hormone concentration also decreased to the prepubertal levels. These sex hormones remain suppressed for as long as the therapy is continued. And once you stop the therapy, the puberty promptly resumes, typically at a pubertal chronological age. So it's very important to continue and follow up and assure the compliance to these GnRH agonist injections or the therapy, whichever route you may use. Now, if it is a gonadotropin independent variety, it will not respond to the GnRH agonist. Treatment actually has to be directed towards the underlying pathology. Children with tumors of the testes, adrenal glands, and ovaries need to be treated surgically. If there is an HCG secreting tumor, it requires combination of surgery, radiation, and chemotherapy, depending on the site and the histological typing of the tumor. A functioning follicular cyst of the ovary will regress on its own, and a conservative management may be decided for this girl. Children whose sexual precocity is caused by exposure to exogenous sex steroid, this exposure has to be removed. Children with identified defects in CH, again, we need to go in for a glucocorticoid therapy for CAH. Now, another important cause or variety or type is the isolated premature menarche. And this is a diagnosis of exclusion. So extensive evaluation of the girl has to be done. Then only you can reach to the conclusion that it is an isolated premature menarche. There will be vaginal bleeding, but there will not be any other secondary sexual characteristic. It is rare. However, we have to carefully exclude vulvovaginitis, any foreign body, and of course, the sexual abuse also has to be ruled out in these girls. Early menarche has large number of physical and psychosocial effects, and we need to really support these girls. The parental support, as the peer support and the family support is required. As there is chance of short stature, these girls are very immature, so there is difficult management of menses, depression, poor study, lonely and poor social life are common. These girls may also suffer from menorrhagia and anemia, obesity, and metabolic syndrome. There could be an early initiation of smoking or drug abuse, and thus counseling is very important in these girls. There could be an early first sexual intercourse, chances of sexually transmitted infections, teenage pregnancy. Also later on in life, there could be chances of PCOS, cardiovascular disease, breast and endometrial cancers. Asthma is also linked with early menarche. So multidisciplinary approach is so very important when dealing with these girls with gentle handling, tender loving care, and you need a pediatric endocrinologist, a psychologist, and counselor to so as to give good outcome and support these girls. What we can advise is taking green, rich food, vegetables, avoiding fast food and animal proteins, avoiding use of plastic containers for food, weight control, exercise, less use of cosmetics, and avoid environmental pollution, and keep away from sexual material and media. So these, as you can see, are very, very important. Evaluation is important, and starting treatment early and supportive management is also important in these girls who present with early menarche. So we come to the take-home messages, which is like very important one is sensitive handling of the young girl and parents. Thorough evaluation. Why? To rule out the CNS lesion, we need to differentiate between GDPP and GIPP so that we can start appropriate treatment. Treatment should be aimed to diagnose serious condition and to treat, then proper follow-up, arrest of excessive maturation, avoidance of sexual abuse, assurance and counseling of the parents. Parents have a big role to play, a very important role to play in prevention of depression and psychosocial issues of the child. So support to the parent is also an important entity in management of precocious puberty. So thank you very much for patient listening to this very important topic. And thank you, Foxy, for giving me this opportunity.